Next, we have with us Dr. Dhalia Arancel from Philippines. She is currently the Dean of Jose Maria College of Medicine in Davao City, Philippines. She's a senior consultant in Department of Anesthesiology, Southern Philippines Medical Center, SPMC. She's the Vice President of Regional Anesthesia Society of Philippines, RASPHIL. She is a board member of the Asian Oceanic Society of Regional Anesthesia. I have great pleasure in presenting to you Dr. Dhalia Arancel.
Good evening. I'm Dr. Dhalia Arancel. My talk is on adjuvants to local anesthetics, my preferences. The objectives are the following: to discuss the importance of adjuvants, to identify the adjuvants commonly used and their side effects, and to discuss the preferred adjuvants. The use of adjuvants to local anesthetic is continuously evolving, where newer agents are utilized to improve the efficacy and safety of analgesia. The goals are the following: to decrease the dose of local anesthetic, increase analgesic effect and onset, and with no or less side effects. The use of different adjuvants creep into our clinical practice, but its use is not approved by authorities. Clinical studies to support these agents have been proposed, but details of its side effects to the nerves has not been fully visible, or its example is the neurotoxicity. The rationale of using adjuvants: we know that pain transmission involves different and several neurotransmitters are not easily blocked by a drug or a technique. So this allows us to use the multimodal approach. What are the agents for adjuvants? Opioids are the oldest adjuvant used in the neuraxial block. Examples are the morphine and fentanyl. Then we have the alpha-2 agonist. Examples are the clonidine and dexmedetomidine. Then we have the vasoactive agent, the epinephrine. The anti-inflammatory agents, example is the ketorolac. Then the steroids, example the dexamethasone. Then the other additives like midazolam, sodium bicarbonate, magnesium sulfate, and ketamine. Now for the opioids, during inflammation, the receptors are expressed at sensory fibers and immune system, and this will enhance the ability of the opioids to reach the target sites. There is also the axonal transport of opioids, but it may not reach the site of inflammation or the receptors. Buprenorphine, tramadol, plus the local anesthetic from some studies will increase the duration of sensory blockade in peripheral nerve blocks. Blockade of the receptor agonist helps suppress afferent nociceptive input from pain sites. Then we have the alpha-2 agonists. In the meta-analysis, clonidine prolonged postoperative analgesia for 2 hours. And dexmedetomidine, used in brachial plexus blocks, can increase the sensory blockade, but the side effects are hypotension and bradycardia. Then we have the vasoactive drugs. Drug that is the epinephrine. This is used for a very long period to prolong the action of local anesthetic by preventing the systemic reabsorption. This is the oldest adjuvant that will potentiate the local anesthetic action by direct action resulting in the presynaptic to inhibit the release of the neurotransmitter from A delta and C fibers. The disadvantage is ischemia due to its vasoconstricting effect, leading to the permanent damage and the perineural administration of epinephrine may have detrimental effects on the nerve in patients with diabetes mellitus and hypertension. Then the steroid. It has great heterogeneity of the results of studies, especially the duration of the sensory blockade. But it is useful due to its anti-inflammatory effect by its capacity to alter the release of inflammatory mediators, reduce ectopic neuronal discharge, and also inhibit the potassium channel mediated discharge of the C fiber. Then the NSAID. During inflammation, this inflammation can induce the COX-2 production and then the release of prostanoids that will sensitize the peripheral terminals and will produce the localized hyperalgesia, and this is blocked by NSAIDs. Thought of spinal or peripheral nerves may be more effective mode than intravenous and intramuscular. So, among this, adjuvants, what are my preferences? Number one, it's the dexamethasone. It has a positive results even in large amount of tissue trauma, though its role in peripheral nerve block is still unclear. According to Mita et al. In 2020, using 4 milligrams and 8 milligrams in the peripheral nerve blocks can increase analgesia. That if you add it to short-term action local anesthetic, it can increase from 172 to 295 minutes. And if it is added in long-term action local anesthetic, it can increase to 419 to 557 minutes. Then according to Hisen et al. In 2019, that there is a high level of evidence that intravenous dexamethasone of 8 milligrams improves postoperative analgesia after the spinal anesthesia. Dexamethasone is effective in prolonging the local anesthetic action in a variety of blocks, such as the epidural, transabdominal block, and fascia iliaca block, without any significant side effects. And this is supported by the study of Kim et al. In 2017. The second is the clonidine. Clonidine works through hyperpolarization of nucleotide-gated ion channel for in vivo elongation of nerve blockade by the local anesthetic. In several studies, including my studies documented in 2013, there is an increased analgesia when clonidine is given in spinal for 2 hours. And I have documented that there is no significant hypotension and bradycardia if it is given in 15 milligram dose in a separate syringe and given prior to the local anesthetic and in the subarachnoid. So what are my take-home messages? Adjuvants, we know, can increase the duration of action of local anesthetic, and we need to have the increase in the sensory blockade. So, it is for us to choose the adjuvant with no or low side effects. You have to document on your own the outcomes of the adjuvant that you used so you can come up with a preferred drug that you are confident of using. Thank you very much for your kind attention. Before that, these are the references that I used for this study, for this talk. Again, thank you for your kind attention.